Continuing with our lecture on insulin, oral hypoglycemic agents, and glucagon, today in this lecture we'll be talking about diabetes. We're going to look at the types, we're going to look at the symptoms, we're going to look at the complications, we're going to look at the treatment goals. So these are the aspects that we intend to cover in this lecture. Okay? All right. So, diabetes. Okay? So what's the definition of diabetes? So diabetes is a group of metabolic disorders characterized by hypoglycemia. Okay, so hypoglycemia is the hallmark of diabetes. Okay, and when we say metabolic disease, metabolic disorder, we mean that there are disturbances, in carbohydrate, fat, and protein metabolism. Okay. So these aspects would become apparent when we continue our discussion of diabetes. So the hypoglycemia itself, there we go. It is hyperglycemia. Okay, so sorry for that. Characterized by hyperglycemia. Okay, so hyperglycemia itself could be due to decreased insulin secretion or decreased glucose utilization or increased glucose production. So it would be quite intuitive to us to think, what are we going to do about hyperglycemia? So we're going to either increase insulin secretion or we would try to increase glucose utilization, or we would try to decrease glucose production. So that gives us a blueprint of where we're going with this. Okay? Okay, so clinically, to standardize treatment, we tend to classify diabetes. Okay, so let's look at the classification. So how do we classify? Okay, we classify Diabetes Mellitus as into 4 types basically. So the first type is, let's say, number 1 is type 1. Type 1 Diabetes Mellitus. And second is as type 2 Diabetes Mellitus. And type 3 type 3, the third type of diabetes mellitus is called gestational. Gestational diabetes mellitus, meaning the diabetes that is seen in pregnancy. And the type of diabetes that don't fall into these three categories, we categorize them as the fourth category, which is diabetes mellitus due to other reasons. And what other reasons are we talking about? It may be genetic. If it's genetic, we have an example like MODY. What is MODY? Maturity onset diabetes of the young. Okay, so it's got a genetic component to it. Or it could be drug-induced, okay? At various times they have been called iatrogenic diseases and so on. So which are the drugs which are implicated? The drugs that can cause diabetes mellitus. So the most famous of them is glucocorticoids. Glucocorticoids. Okay, which are basically immunosuppressant drugs, but they are glucogenic. Okay, so glucocorticoids, and then there is nicotinic acid, and there's thiazide diuretics. Thiazides. Okay, so and then there are other drugs like gamma interferon. Gamma interferon, diazoxide. Okay, so these also increase the blood glucose. So if we look at these drugs, they are slightly different. These two drugs, they impair beta cell function. And these basically, they worsen the insulin resistance. Okay, but all in all, they increase blood sugar levels. So if anyone asks us which drugs are implicated in glucogenesis, then these are the examples that should come into our mind. Okay, so type 1 diabetes mellitus, what's that about? So in type 1, what is seen is that there is complete or total insulin deficiency. Okay, so there is almost total loss of the pancreatic beta cells here. What is the reason? The reason is there is autoimmune destruction. Autoimmune destruction of the beta cells of pancreas. Okay, so that is what's wrong in type 1 diabetes mellitus. And so there is insulin deficiency. How do we treat? We replace the insulin. Okay, so what's the treatment? We replace insulin. So what is the problem with type 2 diabetes mellitus? The problem can be, there can be normal insulin, there can be normal insulin secretion. This could be associated with insulin resistance. So the tissues that normally take in glucose, like in the periphery, like the skeletal muscles or the adipose tissue, they might develop a resistance to taking up of glucose. So as a result, what happens is the blood sugar rises. Okay, so, but as far as beta cell function is concerned, there might be the beta cells, the number might be normal. But then that needn't necessarily be true. Okay, there can be reduced number of beta cells as well. Okay, but the problem is there is still, in such case, there would still be reduction in the quanta of insulin that is secreted. Okay, so here what do? We have a viable, so the overlying idea being that we have viable beta cells. Okay, and if these viable beta cells are not producing enough of insulin, then what we can do is to stimulate the viable beta cells to secrete more of insulin. Okay, and what do we use for that? For that we use oral hypoglycemic agents. Okay, so the spectrum of type 2 diabetes mellitus is ranging from normal insulin secretion with insulin resistance or decreased secretion, with with resistance, okay, and so on and so forth. Okay, so mostly what is observed is there is a decrease in secretion with insulin resistance. So because this is the most common type that's seen, the therapeutic option is to stimulate the viable beta cells to increase the concentration of insulin. Okay, and the agents that we use are oral hypoglycemic agents. Okay. Then there is gestational diabetes mellitus. So this is diabetes mellitus which is seen in pregnancy. Okay, so the option would be to either use oral hypoglycemic agents or to use insulin in this case. But the problem is oral hypoglycemic agents, there is some bit of evidence showing that oral hypoglycemic agents are teratogenic in pregnancy. Okay, so what is teratogenicity? It is the abnormalities in the developing fetus caused by due to several reasons, and in this case due to drugs. So oral hypoglycemic agents can be teratogenic. So what's the option here? Insulin, of course. Okay, so how do we manage this? We replace the insulin. Okay, so that's the drug of choice. Okay, can some of the oral hypoglycemic agents be used? Yes, there are reports of anecdotal use, and in some jurisdictions, physicians use oral hypoglycemic agents. Okay, but to be on the safer side, insulin would be has got better evidence. So yeah, so that's gestational diabetes mellitus, and the diabetes mellitus, due to other reasons, we have listed, and prime among them being drug-induced diabetes mellitus. Okay, so glucogenic drugs is what we have listed out here. Okay, so that is the classification of diabetes mellitus. Okay, so now the question is, okay, so there are the different types. So how do we assign patients as being diabetic? Okay, so what's the diagnostic criteria? Okay, so that's what we're trying to look at now. So let's look at how we determine whether the patient has diabetes. So as in other clinical situations, it's based on evaluation of the patient, and the evaluation of the patient, we understand what are the symptoms, okay? So evaluation of the patient leads us to the symptoms, okay? And the presenting symptoms, if it is, say, the polyuria, polyphagia, or polydipsia, okay, meaning you're feeling thirsty, you're urinating, and you're feeling hungry, you are obsessed with eating, and you have some bit of weight loss. Okay, so that is a red flag that tells you that you might be diabetic. Okay, so yeah, so those are the presenting symptoms commonly seen in diabetic patients. Okay, so the patient comes, the patient tells the symptoms, and then you need to, you have an idea that the patient might be diabetic, but then you base your, because you're practicing evidence-based medicine, we need to look at the labs. So we send the patient for labs, okay? And what are the labs that we are looking at? We are trying to see, what are we trying to assess? What are we trying to assess? Using labs, we are trying to assess whether the glucose homeostasis is maintained in the fasting state or the fed state. Okay, so the normal blood sugar is maintained both in the fasting state and the fed state. So the idea is the body able to maintain it in the fasting state or the fed state? Okay, and if it is not, then it might be pathological. So that's what we're trying to test by using labs. So for the fasting state, what do? We do, it's not very difficult, we do a fasting blood sugar. Okay, fasting blood sugar. Okay, so what does fasting here mean? We mean calorie restriction for 8 hours. Okay, so the patient is not supposed to take meals within before. In the previous 8 hours that you're subjecting the patient to do a test. Okay, so yeah, so that is fasting and fasting blood sugar. So what's done is the patient after a fast, but then there is only calorie restriction, meaning water is not restricted. Okay, not restricted. Okay, so such a patient after an overnight fast comes to the lab, and in the lab blood is withdrawn, and the plasma glucose level is determined. Okay, or the glucometer could be used. Okay, but the gold standard would be to determine the plasma glucose level. All right, so fasting blood glucose is done, and then what about the fed state? Okay, so after the plasma blood sugar is taken, the patient is advised to consume 75 grams of glucose. Okay, so that test is called the oral glucose tolerance test. Okay, so oral glucose tolerance test. Okay, so oral glucose tolerance, OGTT. Okay, so the oral glucose tolerance test is done. So what it is the patient has come after calorie restriction and the blood has been withdrawn, and then the patient would be administered 75 grams of glucose. Okay, so this practically what happens is 75 gram of glucose is dissolved in 300 ml of water. Okay, and then the patient is asked to drink it within 5 minutes. Okay, so that's how it is. So 25 grams in 100 ml. Okay, so that's how we get 75 grams in 300 ml. Okay. So let me write it down here, 25 gram per 100 ml. Okay, so yeah. So that way, 75 gram of glucose is administered, and then after 2 hours, again, blood is withdrawn, and the blood, after 2 hours, blood is withdrawn, and again the plasma glucose level is determined. Okay, so what about if it's a child? So obviously 75 grams wouldn't be given to a child. So how do we calculate that? It's 1.75 grams per kilogram body weight to a maximum dose of 75 grams. Okay, so that is how you would calculate for children. Okay, okay. So yeah, but remember, this is a patient who is coming to the lab, so it would be ideal if all the tests that can be done that gives maximum information for management. If it can be done in one sitting, then it would be convenient to the patient. So usually what is done is when the fasting blood sugar is removed, when the blood is taken for determining fasting blood sugar, at the same time, the urine sample is also collected. Okay, so mid-catch urine sample is also taken, and it is subjected to glucose. Okay, glucose, the presence of glucose or ketone bodies. Okay, so predominantly we're checking for this, but also creatinine can be checked. Okay, so the creatinine clearance, that will give us an idea of the renal status of the patient. And during the glucose tolerance test, we had to collect it after 2 hours, but we can also collect it at 1 hour. Okay, after 1 hour also, we take the blood sample, and we also take the urine sample. And why we could do that, it's inconvenient to the patient because we are withdrawing another blood sample, but we'll discuss why that might be helpful. And after 2 hours, we do the same thing. We withdraw blood. The blood is withdrawn, and urine sample is taken as well. Okay, So again, all these determinations are done. Okay. And it's easy for the lab too, because this can be processed at the same time. Okay, so yeah, so this would give us an idea. This would give us an idea about the random blood sugar. So random means it can be taken at any time. So in this case, we are using this time point, the 1 hour after the oral glucose, as a time point to determine random blood sugar. So the idea is, if we concurrently we are able to do this, the urine analysis as well, and in this manner suggested, then it gives us maximum information with regards to the patient. Okay, so that's done in is done in some clinical settings. All right. Okay. But either way, this is the recommended tests that are to be done to determine whether the patient is diabetic or not. The other important lab, in addition to determining the homeostatic ability of the patient in the fasting state and the fed state, what is done is the HbA1c is checked. Okay. So let's see what's that all about. HbA1c. Okay. So what is this? This is glycated hemoglobin. Okay. A. Glycated hemoglobin A. Okay. So yeah. So this is determined. So what is this HbA1c? So what happens is, if hemoglobin is in the presence of glucose, then there is a non-enzymatic glycosylation of hemoglobin. Okay, so the hemoglobin would be glycated, or the glucose molecule would get attached to the hemoglobin molecule. And that's what we call non-enzymatic glycosylation. Now, this, the amount of glycosylation that happens is directly proportional to the time the hemoglobin is in contact with glucose. Okay, so what's the half-life of, the life of red blood cells? Okay, so red blood cells contain hemoglobin. Okay, and the life of a red blood cell is 120 days. Okay, so during the 120 days, if the hemoglobin has been in contact with increased amounts of glucose, then it would be more glycosylated. Okay, and if the glucose has been well controlled, then for 120 days, this hemoglobin would have been in less contact with glucose. As a result, less glycated hemoglobin would have been produced. Okay, so this gives us an idea of the glucose control for about 120 days. Okay, so what has the glucose been adequately controlled? So that's the information we get by assessing hemoglobin A1c. Okay, but is it the gold standard to check whether a person has got diabetes? No. Why? Because there are some conditions, pathological conditions, that may interfere with this result. Okay, for example, if the person has got hemolytic anemia, then obviously the RBC might have less than 120 days of survival. Okay, so that might interfere. All right. So it's not the gold standard, but still it gives fairly good idea about how the glucose has been controlled, whether it has been controlled for 120 days. Okay, has there been adequate control? So let's look at the levels So HbA1c, it's determined as a percentage, milligrams per, it's a percentage, okay? And because there is a linear relationship, there is also a relationship between the blood glucose level, okay? So this is milligram per deciliter, okay? So if we draw, let's draw a table and see how it looks like. So if it is 5, 6, that's 7, 8, 9, 10, 11, and 12. Okay, so let's try and see a correlation. We said that there is a linear relationship between these levels. So let's see what is the relationship. So if it's 5, then it is 97 milligram per dial for 120 days is what we can infer, and so on and so forth. And for 11, it's 269, and for 12, it is 98. Okay, right. So this could be a ready reckoner for us. Okay, so when we get back the lab results, if this is in our mind, we can have a good idea about whether the patient's blood sugar has been controlled. Okay. All right. So let's put this in context. How is this information useful for us in determining whether the patient is diabetic? Okay, for that, let's see what are the labs results that we get. We get the fasting blood glucose, and we get the 2R plasma glucose, and we get the HbA1c data. Okay, so let's see. So in a normal person who is not diabetic, normal meaning statistically normal, the normal glucose tolerance, let's write the normal let's write it there as normal glucose tolerance. Okay. And let's see what's there in a pre-diabetic patient. And diabetic, okay. So we are looking at the normal glucose tolerance level for fasting blood glucose. It would be 100 milligram per deciliter. In a diabetic patient, it would be 126 milligram per deciliter. So that's the cutoff, okay? So anything over 125 is a diabetic patient, okay? But assuming that the test has been done at least on 2 occasions, it's not like you get a single test and you obtain this and you classify the patient as a diabetic, okay? So pre-diabetic would be if the fasting blood level is between 100 and 125 milligram per deciliter, okay? And the 2R plasma glucose in a normal individual would be 140 milligram per deciliter. Right here it would be, in a diabetic patient, it would be 200. Okay, so that's again the cutoff. So between these two is the pre-diabetic. Okay, so that would be 140 to 199. Okay, and what about HbA1c? So this is less than 5.6% in an absolutely normal individual, and it would be 5.7 to 6.4 in a pre-diabetic patient, and greater than 6.5% would be what would be in a diabetic. So what is 6.5? Right, so it's greater than 120. 26 milligram per deciliter, right? So, yeah. So that correlates with what we have written here. Okay. So it's based on this test that we could say whether the patient is diabetic or not. Okay. So then the question is, how do we know whether the patient is a type 1 diabetic or a type 2 diabetic or a gestational diabetes patient? Well, we have initially assessed the patient. Okay. So we would obviously know whether the patient is pregnant, all right? And whether the patient is type 1 patient, we would know by looking at this C-peptide level, okay? So only if the beta cells are viable, only then we would get C-peptide in the blood, all right? So that is one of the things that could be done. But then assessing a patient would give us the idea, okay, because the makeup of the patient is different, okay. So type 1 patients would, they would be thin, they would show signs of wasting, and type 2 diabetic patients would be more well endowed, okay? So, meaning they would be they tend to be overweight, okay? So, an idea just by looking at the patient, we'd have an idea, but then it's always wise to confirm it with lab tests if they exist, okay? And, so in this case, the random blood sugar should also be greater than 200 milligram per deciliter, okay? So, so those values enable us to diagnose a patient as to whether the patient is diabetic or not. Okay, so in type 1 diabetic patients, what do? We replace the insulin. In type 2, we give oral hypoglycemic agents as long as there are viable beta cells. If the beta cells are not present or they have declined absolutely, then insulin becomes a choice in type 2 diabetic patients. Okay, so that is the reason why in legacy textbooks you can see that they classified insulin as insulin-dependent diabetes mellitus and non-insulin-dependent diabetes mellitus. But current treatment shows that we can give insulin even to non-insulin dependent diabetes mellitus. So it doesn't make sense to classify it as IDDM and NIDDM. Okay, so we stick on to what we have classified as type 1, type 2 gestational, and the diabetes mellitus that don't fall into the above the other 3 categories. Okay. All right. So we have talked about in the test we have talked about the goals. Okay. So now the question is, how do we know that this is normal? Okay. How do we know that this values makes a person pre-diabetic or diabetic? Okay. So before we go into that discussion, let us just talk about pre-diabetic patients. Okay. So pre-diabetic patients, they have not yet been clinically classified as a diabetic patients, but they have the risk factors associated with them becoming a diabetic patient. So our goal would be to slow the entry of a pre-diabetic patient to a diabetic patient, okay, because we cannot change the disease process, but we can certainly slow it down. So we can do lots of interventions, okay, we can do lifestyle interventions. So those things will be clear when we go into the next topic that we're going to discuss. We're going to talk about clinical studies, okay. So let's put another word, landmark clinical studies that has led us to this information and our current intervention. Okay. So all this data has come from the landmark clinical trials. Okay. And that is the basis of the practice that we do. So it is useful for us to learn a bit about those landmark studies. Right, so we're going to talk about clinical studies. And there have been clinical studies, landmark studies for type 1, diabetes mellitus, and for type 2. Okay, so the most important landmark study for type 1 diabetes, in fact there are two. Okay. So the most important one being the DCCT trial. Okay. So what is this DCCT? It is diabetes control and complication trials. Okay. And there has been a follow-up of the patients who were enrolled in DCCT. So after this trial was over, the patients who were recruited have been followed up in an observational study. And the name of that observational study is, I think it is EDIC. Okay. So what was EDIC? EDIC is epidemiology of diabetes, interventions and complications. Okay. Interventions, let's bring it here, interventions and complications. Okay, so basically it's the continuation of the DCCT study. Okay. And in type 2, there has been there is a landmark study which is UK prospective diabetes study. Okay, UK meaning United Kingdom. Okay, UK prospective diabetes study, and the acronym for that would obviously be UKPDS. Okay. So, prospective diabetes study. So let's look at what happened here. Okay. So in the DCCT, let's write it down here somewhere. DCCT. What was done was, so in every clinical trial you ask a question, okay, and then you try to gather evidence with regards to that question. Okay, so the question that was asked was, so if you give an intensive treatment, would intensive treatment reduce the frequency, so would frequency and severity of complications. Okay, diabetes complications. Okay, so that is the question that is was asked in this trial. Okay, so it's asking would intensive treatment decrease frequency and severity of diabetes mellitus? Okay. So intensive treatment. So they need something to assess the treatment. And what are they assessing? The blood sugar. Okay. So intensive treatment would mean you're giving drugs which reduce your blood sugar. Okay. So that blood sugar is what you're assessing basically. Okay. And then you're looking at the complications, the clinical picture of the patient. So that was what was done in DCCT. So for that, for any clinical trials, you need patients. So in this case, 1,441 patients were recruited. Okay. Patients were recruited. Okay, so patients, okay, meaning they all had diabetes, and they were, the criteria for the patients were that a group of patients were not supposed to have retinopathy, and they should have had diabetes for 1 to 5 years. Okay, so this was one of the bases in which patients were recruited. The other was the patient should have mild retinopathy, okay, and they should have had diabetes for about 15 years. Okay. So this was what was advertised. We are going to do a trial and we need volunteers for this. And yeah, based on this criteria, they recruited. So they had 726 patients belonging to this criteria, and they had 715 patients belonging to this criteria. Okay? So what is evident here is that these patients are more advanced. They are having more advanced disease. Then what happened was, these two groups of patients were randomly assigned. Okay, so they were randomized, and then based on the group, they would be assigned to conventional therapy, and intensive therapy. Okay, so what was the conventional therapy? The conventional therapy was insulin. Okay. So this study was conducted in 1982. So obviously at that time we had insulin. So the conventional therapy was insulin, and it was conventionally given 1 to 2 injections per day. And to the intensive group, they were administered 2 to 3 injections per day. Okay, or they were given continuous insulin infusion using a pump, and they were frequently monitored. Okay, and then the dose was adjusted. So that a target blood sugar level was maintained, right? Okay, and then these patients were followed up for 6.5 years. Okay, at the end of 6.5 years, the data was analyzed. Okay. And what was what was very apparent was, in the intensive arm, Okay, so let's write intensive and conventional. Okay, so in the intensive arm, what was observed was the glycated hemoglobin, HbA1c, was 7.2%. Okay, and in the conventional, it was 9%. So what was why are they checking this? Because they want to see if the glucose has been adequately controlled. Okay, so in the intensive, it was adequately controlled. That's the reason why HbA1c was 7.2. Okay. Whereas it was not adequately controlled in the conventional regimen. Okay. And then some problems were checked. For example, retinopathy. Okay, so remember that the patients who were recruited, some of them had already mild retinopathy, and some people did not have retinopathy, but they were randomized and given these therapies. So what was observed was the retinopathy, the risk of retinopathy. So let's write here risk. Okay, risk is what we are talking about. So risk of retinopathy in the intensive treatment reduced by 76%. Okay, so meaning even people who had retinopathy, then the progression reduced. Okay, and microalbuminuria. Okay, so what is microalbuminuria? The presence of albumin in the urine. It's not supposed to be present normally. Only when there is a renal compromise, there is a problem with the renal tubules, only then we get microalbuminuria. Okay, so that is, we say, greater than 40 milligram per deciliter per day. Okay, so that is microalbuminuria. And that, the risk of, so initially there were people who did not have microalbuminuria. So their risk decreased by 54%. Okay, and the risk of progression from microalbuminuria to albuminuria. So what is albuminuria? We define it as greater than 300 milligram per 24 hours. Okay, so this is not milligram per deciliter, it is per day. Okay, yeah, so that is albuminuria. So the risk of conversion from microalbuminuria to albuminuria, this risk also reduced by so this was sorry. Microalbuminuria, the risk was reduced by 35%, and this conversion to albuminuria was reduced by 54%. Okay, and neuropathy was checked. Okay. Okay, so pathy means disease of the neurons. So the risk was reduced by 60%. Okay, now all this risk is compared to the conventional. Okay, so the conventional people had greater risk, right? Okay, so what is the conclusive evidence? So the evidence is the evidence for the study, from the study, is that improved glucose control, okay, with intensive therapy can reduce microvascular complications and can slow the progression of established macrovascular disease. Okay, so what is microvascular and macrovascular? We will be discussing shortly. So just hold on to that thought. Okay. So then what happened was, these patients in the DCCT, the patients enrolled in DCCT was followed up in the EDIC trial. Okay. Okay. And from both these studies, the goal was set. Okay, so the treatment goal. Goal was set as follows. Okay. So the treatment goal got set. And what was the treatment goal? The HbA1c level should be less than 7%. The preprandial the preprandial is before food. Okay, the fasting glucose. It should be in a target range of 70 to 130 milligram per deciliter. And the peak postprandial glucose should be less than 180 milligram per deciliter. Okay, so this became the goal for patients with diabetes mellitus, and it's based on this clinical studies. Okay, so the current guidelines, so there are guidelines from the current goal. Okay, and this is based on the guideline of the American Association of Clinical Endocrinologists. Okay, so they have set an even even difficult target, okay, than this for the diabetic patients, and the target is to be less than 6.5 milligram, 6.5%. Okay, so it said HbA1c is measured in percentage. It should be less than 6.5, and the fasting glucose should be less than 110 milligram per deciliter, and the postprandial glucose should be less than 140 milligram per deciliter. So the point is, this goal of HbA1c becoming less than 6.5, it means that the blood glucose should be controlled throughout the day. So if there is a massive fluctuation, okay, fluctuation of glucose, of blood glucose should be avoided, because fluctuation can result in increased HbA1c. And this fluctuation of blood glucose is called glucose excursion. Okay, so we need to reduce the glucose excursion, meaning the blood glucose should be continuously maintained at a constant level. So how can a patient do that? The patient has to take responsibility. Patient has to take responsibility. Okay, which means as healthcare providers, we need to really educate the patient so that the patient is able to take responsibility. And if the patient takes responsibility, the patient can meet these goals. Okay, so yeah, okay. Okay. It was also observed in the DCCT. Okay, the other thing that is observed, let's write note. It was observed in the DCCT, the Diabetes Control and Complications trial, that the tight control of blood sugar was associated with hypoglycemia. Okay, meaning there were instances where the blood sugar really went below normal. Okay, so therefore, patients should be advised that in type 1 diabetic patients, if you are on tight glucose control, you may be liable to hypoglycemia, and therefore you should be advised to keep absorbable carbohydrate at hand. Okay, so if there is an instance of hypoglycemia and it is not severe and the patient is able to consume food orally, then 15 grams of carbohydrate can be given, and this would raise the blood glucose by 38 milligram per deciliter in a time frame of 20 minutes. Okay, so this is kind of a rule of thumb. Okay, so 15 grams of carbohydrate could increase the blood sugar level by 38 milligram per deciliter in around 20 minutes. Okay, so yeah, so yes. So now the question is, where could the patient get 15 grams exactly? Okay, so why 15 grams? Why can't it be 30 grams? It's because if excess of glucose is given, then that can lead to hyperglycemia. We don't want that happening either. Okay, so this 15 gram would be available from about 3 glucose tablets, or 1 tablespoon of sugar dissolved in water, or 3 conventional packets, okay, packets of sugar, you know, the ones that's available commercially, the small packets. Okay, so the 3 packets of sugar dissolved in water again. Okay, would contain about 15 grams of absorbable carbohydrates, or 175 ml of juice, fruit juice, which could be like orange or apple. Okay, or sweetened soda, aerated drinks. Okay, but not sugar-free. Okay, so if it contains aspartame, that won't help. All right. Okay, or 1 tablespoon Uh, so 1 tablespoon, they measure the volume would be 15 ml, okay, of honey. Okay, so why is this important for us to learn? Because this helps us to educate the patient. Okay, it helps us to educate the patient as to how to prevent episodes of hypoglycemia in absence of expert medical help. All right? Okay, so this is hypoglycemia when the patient can consume things orally. So what if the hypoglycemia is severe? Okay, the patient is unable to take stuff orally. Okay, so the patients should also have an emergency glucagon kit. Okay, so glucagon is a counter hormone to insulin. Okay, so the patient should also have an emergency glucagon kit in case the hypoglycemia is severe, and severe meaning the patient is unable to consume things orally. Okay, so the patient should be trained to use this glucagon kit, should be trained to be able to administer 0.5 to 1 milligram either subcutaneously or intramuscularly if the episode is really severe. Okay, so this, so the patient should be trained. Okay, all right. So the DCCT also enabled one to understand the acute complication. Acute complication of type 1 diabetes mellitus. Okay, and the most important acute complication of type 1 DM is ketoacidosis and hypoglycemia. Okay, so hypoglycemia we have discussed above. Let's look at what is ketoacidosis. So what happens is insulin deficiency increases the concentration of the counter-regulatory hormone, and which is increases glucagon. Okay. And this glucagon brings about lipolysis. So what is lipolysis? The breakdown of triglycerides, okay, to fatty acids and glycerol. So this lipolysis results in fatty acids. Okay. So liberation of fatty acids where into blood, and through the blood it reaches the liver. Okay, so lipolysis where? In the adipose tissue. Okay, so this fatty acids reaches the liver, where the liver produces ketone bodies. Okay. So what is the problem with ketone bodies? So these ketone bodies they can result in the deterioration of the mental status. Okay, so the patient may progress to coma. Okay, so cognitive ability can decrease, and the patient can go into coma, and so the symptoms would be the symptoms of diabetes plus symptoms of diabetes mellitus plus certain symptoms associated with ketone bodies. So one would be acetone breath. Okay, it has got the people with ketosis will have a typical acetone breath, and there can be, as we said, deterioration of mental status. Okay, so cognitive ability. ability may decrease. Okay, and what's the symptom of diabetes mellitus? We have said the polys, okay, the polyuria, polyphagia, polydipsia. Yeah, and there can be a typical type of breathing that can be observed in the patient. So that is Kussmaul's breathing. Okay, so these would all be indications of a person having ketosis. Okay, so that needs to be managed. So this is a life-threatening emergency. Okay, so the thing to remember is if a patient is unable to go to a clinical facility immediately, the patient should be advised to drink lots of water. Okay, so ketone bodies are water soluble, so that's the idea. Okay, all right. So that is the one of the most important acute complications of diabetes mellitus. The other being hypoglycemia. So all this information came again from the these clinical trials. Okay. So diabetes is a chronic disease. Okay, it's a chronic disease, meaning the disease is not cured, it's just managed and the progression is slowed, but the disease as such remains. Okay, so it's a chronic disease, and therefore, if it is not treated, it can lead to chronic complications. Okay, so it's a chronic disease, it will lead to chronic complications. So this is the reason why diabetes should be treated. Okay, so we treat diabetes mellitus because we want to prevent or slow down the progression to chronic or the instances of chronic complications happening. So what are these chronic complications that we are worried about? The chronic complications are retinopathy, neuropathy, and nephropathy. Okay, and these together they are basically microvascular complications. Okay, and then there is also cerebrovascular, meaning the patient can have a stroke, or peripheral vascular or coronary artery disease. Okay, so these are what? These are macrovascular complications. Okay, so why are we treating diabetes mellitus? Because we want to, why are we treating? Let's write it down here so that we don't forget. Okay, so let's write here maybe so that we don't forget. Why do we treat? Okay, so why should we treat? Okay, so that would be a better question. Why should we treat? Okay, why should we bother? Because we want to prevent acute complications, and we want to prevent chronic complications. Okay. So what are the acute complications we have talked about? Hypoglycemia, ketoacidosis. Okay, chronic complications, we have microvascular and macrovascular. Okay, so that is why diabetes is also in many aspects thought of as a atherosclerotic disease too. Okay, because it basically causes changes in the vasculature. All right. Okay, so this is the reason why we need to be treating diabetes, why we should be concerned about the blood sugar level, why we should know the normal blood sugar levels. Okay. Okay, so what is important to understand here is that in chronic patients, there can be comorbidities as well. Okay, so as the disease progresses and as the age increases, there will be comorbidities too. So blood sugar level control alone is shouldn't be the goal. Okay, so the target blood pressure should be less than 140 millimeters of mercury. Okay. Okay. 80 millimeters of mercury, and the LDL should be less than 100 milligram per deciliter. Again, we can prevent atherosclerotic problems. The triglycerides should be less than 150 milligram per deciliter. And the HDL ideally should be greater than 40 milligram per deciliter in males, and it should be greater than 50 milligram per deciliter in females. Okay, so basically insulin, treatment of diabetes mellitus becomes a multidisciplinary approach. Okay, and since the patient is taking responsibility, there is a big role for diabetes educators, okay, who are specially trained to do just that. Okay. Okay. In addition, the patients should be counseled to advise. So, advice to patients. Okay. Okay. So, to patients. So the risk would be the patient may have retinopathy, right? As the disease progresses. So the patient should check, should go to an ophthalmologist and check within about 5 years of diagnosis. Okay. 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 So it's a slow progressing disease under adequate control. Therefore, every 5 years, if the patient goes and checks the eye, okay, ideally, it can be annual, on an annual basis would be most beneficial, but 5 years is acceptable. Okay, and to check for nephropathy is another risk. So the renal function should be checked. And okay, so that maybe even dose adjustments or drug adjustments can be done, and there can be neuropathy. Okay. So neuropathy is usually associated with the foot, so foot care. This again, on an annual basis, would be most beneficial to the patient. And cardiovascular system, so it is an atherosclerotic disease, as we mentioned, so cardiovascular system should be regular. Okay, it should be regularly evaluated. And the other things, so other things that need to be checked, again, because it's a vascular complication, there can be erectile dysfunction. Okay, there can be depression, or sometimes even thyroid diseases can be seen. So this also needs to be evaluated. So from all these things, what we understand is the aim is not only reducing the biochemical parameters, it is also to improve the quality of life of the patient. Okay, so that is another goal of the overall therapy. All right? Okay, so which brings us to the landmark studies for type 2 diabetes mellitus. Okay, so let's now look at the type 2 landmark studies. for type 2. And the most important study, as we mentioned previously, was the UKPDS, okay, the United Kingdom Prospective Diabetes Study. And what was the acronym? UKPDS, okay? So here again, patients were recruited and they were administered standard intervention and intensive intervention. Okay, so the intensive intervention in this case was with oral drugs like sulfonylureas, biguanides, and the specific type of biguanide was metformin. Okay, so metformin was used here. Again, the dose was adjusted in such a way that the blood sugar level, the target blood sugar level was 108 milligram per deciliter. Okay. So the dose was adjusted such that the patient had this blood sugar level in the intensive arm of the trial. So what was the standard intervention? The standard intervention was lifestyle intervention. So what is lifestyle intervention? It's decreasing in the body weight, exercising, having appropriate food. Those kind of things are called lifestyle intervention. So in our lecture here, we're not going to focus on that. Okay. Lifestyle intervention and pharmacological therapy. Therapy was instituted if the blood sugar level was about 270 milligram. Okay. So if it was less than this, there was no intervention, only lifestyle interventions were given. And what was readily observed was the HbA1c level was increased in the standard intervention. So that is HbA1c was increased in this arm. Okay, and obviously it was reduced in that arm. Okay, and then what was important was some conclusions could be drawn. And the conclusions were that sulfonylureas, here insulin was also used, okay? I forgot to write that down. What was observed was sulfonylureas and insulin, they resulted in weight gain. Okay. Metformin did not show a weight gain. Okay. And there was reduced risk for microvascular complications. Okay, and what were the microvascular complications that we studied? Yes, retinopathy, nephropathy, and neuropathy. Okay, what about the macrovascular complications? Well, there was no statistical difference. Okay, but the microvascular complications, definitely the risk was reduced. Right? Okay, so from both these studies, what we understand is that lifestyle interventions, okay, lifestyle interventions and drug therapy are the two modalities for treatment of diabetes mellitus, and that can reduce complications, and those decrease in complications can increase the quality of life. Okay, so that is the summary of these clinical trials. Okay, and it also sets the goal for, for treatment. Okay, so that is why the clinical studies are important. The importance of the landmark clinical studies. Okay, and right, so when we counsel patients, we know that our advice is based on clinical studies. It's based on concrete experimental data. Okay, so in this lecture, we have talked about the definition. We have talked about the classification of diabetes mellitus. We have talked about the diagnosis. We have talked about the clinical trials. Okay, and these clinical trials helped us to achieve what we just now discussed. And then we also learned that what is the treatment modality. Okay. Okay, here when we say treatment modality, we are talking about medical treatment modality. Okay, so there are other interventions, surgical, there is nutritional, there are lots of other different modalities, but as far as medical modality is concerned, we have learned that for type 1, okay, the intervention is replacement of insulin. Okay, insulin replacement. And for type 2, it is oral hypoglycemic agents, though insulin can be used for type 2 diabetes mellitus. And for gestational, again, the gestational, it is insulin. And what about the other types which don't fit into this? If it is drug-induced, we can change those drugs which are causing diabetes mellitus, or if it is genetic, then again we can use any of these approaches to reduce the blood sugar. Okay, so this is the logic behind the treatment of the different types of diabetes mellitus. Okay, and that is what we have covered in this lecture.